Hello, and thank you all for listening to our presentation. Today we are asking the question, could you brush for better memory? I'm Olivia Hamilton.
I'm Jennifer Maxwell.
I'm Shannon Young.
And I'm Sarah Floyd, and today we're going to be discussing the association between Alzheimer's disease and oral health.
Why should this matter to oral health professionals? Currently, we are missing proper research and/or studies provided on humans, but there is evidence associating periodontal disease to Alzheimer's disease. From personal experience that we get as students volunteering in places such as the Camp Hill Veterans Memorial Hospital and long-term care facilities with CCA students, we think this topic is important and should matter because, according to Statistics Canada, Alzheimer's disease is on the rise in Canada, with Nova Scotia having the highest mortality rate and the highest number of deaths out of the maritime provinces caused by Alzheimer's disease. Another statistic that we found was important was done by the World Health Organization, which declared that during 2020, the number of people aged 60 and older will outnumber children younger than 5. This then clarifies that it is evidently nearly impossible that we would go throughout our entire career without having a patient with this disease in our chair. Our goal for you today is that by the end of this presentation, you will be able to define dementia and Alzheimer's disease, recognize the increasing incidence of Alzheimer's and associated factors, discuss the association between Alzheimer's disease and periodontal disease, apply techniques to improve the clinical experience for those living with Alzheimer's disease, and explain home care techniques for the caregivers of those living with Alzheimer's disease. So, what's the difference? Dementia is a term used to describe a decline in mental ability severe enough to interfere in daily life. Alzheimer's disease, which we will refer to as AD, is a specific neurological degenerative disorder and is the most common factor leading to dementia. Alzheimer's disease gradually destroys the ability to remember, reason, learn, and imagine by complex brain changes following cell damage that will worsen over time. With these associated factors, this is why medical history is especially informational and important. All these factors can aid in the nerves in the brain and surrounding tissues to create plaques and neuroinflammation that results in neurofibrillary tangles. This increases the risk of developing Alzheimer's disease, where the connection between the associated factors and Alzheimer's disease is neuroinflammation specifically. In the early and middle stages of Alzheimer's disease, affected individuals may be painfully aware of their intellectual decline. It is important to support their emotional and mental health with affection and warmth. In the beginning, there is simple forgetfulness, especially due to familiar places or recent events. There also may be personality changes such as restlessness, resistive behaviors like increased stubbornness, distrust, poor judgment, and impulse control. In a patient with mild dementia, good oral health should be quickly restored because of the progressive nature of this disease. Subsequent care should focus on preventing dental disease.
The next stage of Alzheimer's disease is the moderate stage. As for signs and responsive behaviors, as the disease progresses, the ability to perform daily living tasks is lost, and there may be trouble recognizing everyone except the person's closest daily companions. Communication becomes difficult as written and spoken language declines. For oral health care priorities, a patient with moderate dementia may not be as willing to dental treatment as in the earlier stages of the disease. In such cases, the focus of the treatment should consist of maintaining dental status and minimizing deterioration. When possible, complex dental procedures should be performed before the disease has reached the moderate to advanced stage. Their ability to maintain proper daily oral hygiene may become compromised and may require full or partial assistance from a caregiver. The final stage of Alzheimer's disease is the advanced stage. In these last stages of the disease, patients with AD may become bedridden and are unable to recognize themselves or their closest family members. These patients are often anxious and exhibit responsive behaviors that may be interpreted as hostility and uncooperativeness during a dental appointment. These patients are best served with short appointments and non-complex procedures. Use of sedation may be required for more complex and lengthy procedures. Sedative medication should be selected in consultation with the patient's physician. In advanced cases, Eliminating removable prosthetics may need to be considered because of the danger of self-injury. All treatment decisions and home care recommendations should take into account the individual's memory loss, lack of motivation, and reduced cognitive ability. Thus, their ability to maintain proper daily oral hygiene can become severely compromised and will require full or partial assistance from a caregiver.
Periodontal disease and systemic inflammation. The oral cavity normally has several different barriers, physical being the mucosa, chemical being the saliva, and immunological being the immune system, but transient oral bacteremia happens during mastication as well as normal home care such as brushing and flossing. These barriers are compromised by inflammatory periodontal disease because periodontal pockets provide a large surface area and ulcerations in the pocket allow easy access to the bloodstream. This makes it so bacteria can spread via the circulatory system. When an individual has severe periodontal involvement and higher levels of bacteria, there is potential for bacteria to spread via the circulatory system to other parts of the body multiple times per day. Periodontal pathogens and byproducts can induce the formation of pro-inflammatory cytokines. Cytokines can be degraded at inflammatory sites such as periodontal pockets, but when the anti-inflammatory response becomes overwhelmed, it allows cytokines and pathogens to escape into the bloodstream. We know this to be true among our periodontal patients because blood tests show elevated levels of inflammatory markers compared to those individuals without periodontal disease. Periodontal disease and its connection with Alzheimer's disease. The following periodontal pathogens have been found in the brain of individuals with Alzheimer's disease. This shows that they have the ability to get past the blood-brain barrier. This includes AA, Fusobacterium nucleatum, Treponema denticola, and Porphyromonas gingivalis. Cytokines in the brain are attracted to amyloid beta peptides, which results in deposits and further cytokine production. Now we will show a summary of the potential mechanism behind the relationship between periodontal disease and Alzheimer's disease as discussed in current literature. A decrease in cognitive ability and motor function leads to an increase in plaque accumulation, which therefore causes or exacerbates periodontal disease. Inflammation in the oral cavity allows pathogens to cross barriers, which triggers a series of events for tissue destruction. Pro-inflammatory cytokines and pathogens penetrate the brain through the blood-brain barrier. Cytokines and/or pathogens trigger the deposition of amyloid beta peptides in the brain and promote the formation of neurofibrillary tangles. The deposited amyloid beta peptides clump together to form lesions that are associated with Alzheimer's disease. It is these lesions that are thought to interfere with neuronal function and lead to cell death.
Current evidence. So these are results from cross-sectional and longitudinal studies and were approved by the Institutional Animal Care and Use Committee at the University of Illinois at Chicago, also known as UIC in Chicago, Illinois. So Porphyromonas gingivalis was introduced into the oral cavity of 8-week-old mice, which was applied 3 days a week for 22 weeks. This resulted in mice developing chronic periodontitis, which was determined by assessing bone loss around their teeth. An accumulation of amyloid beta peptides were found in the brain of these mice, which, as Jennifer previously mentioned, is a main component of lesions found in Alzheimer's disease in humans. This showed that P. gingivalis can in fact be an initiator of neuropathology consistent with Alzheimer's disease. It was unknown if the invasion of P. gingivalis was the cause of the lesions or if it was the systemic inflammation, but this clearly demonstrates an association between the two. Keeping in mind, the question still remains. Does periodontal disease cause Alzheimer's disease? As of today, more research is needed to determine if a cause and effect relationship exists. In order to determine a causal relationship, more high-quality studies need to be designed and executed in humans. If this was to be discovered as a causal relationship, This would further emphasize the need for prevention, early detection, and prompt treatment of periodontal disease. What is happening in Nova Scotia? Current statistics in Nova Scotia show nearly half of Nova Scotians aged 45 to 64 have moderate to severe periodontal disease, and this increases to 70% for those aged 65 and over. We know this to be true because we are fortunate enough to see these patients firsthand throughout our education at the Dalhousie Dental Clinic and other rotations. 2/3 of those living in long-term care with natural teeth had a gingival index of 2 or more, indicating moderate to severe inflammation. We also have personally experienced this firsthand because, as Olivia previously mentioned, we are extremely lucky to have the opportunity to visit long-term care facilities and Camp Hill Veterans Memorial Building throughout our education here at Dalhousie University. The number of people living with dementia in Nova Scotia is increasing. Estimates show that by 2038, 2.5% of the population will be living with Alzheimer's disease and related dementias. We began this presentation highlighting the fact that it is becoming increasingly likely to see members of the aging population in your practices. These statistics suggest that it is highly likely you will see individuals with Alzheimer's or other related dementias in your chair and their caregivers. It is important for us to aid those living with AD in their oral health and to assist caregivers in providing daily mouth care for their loved ones.
Nova Scotians living in long-term care have very high rates of oral disease, yet have very little access to dental care or dental coverage. So as part of our presentation, we thought it would be a great idea to refresh everyone on some practice techniques to improve patient experience in the chair for those who suffer from Alzheimer's disease. First, creating an individualized care plan is important for these patients. To provide the most optimum dental management to these patients, we as healthcare providers require the knowledge of the stage of the disease, the medications taken, and the cognitive abilities of the patient. From there, we can individualize care to ensure that each patient is getting the health care that they deserve. Timing. Set a routine, time, and place, as familiarity with a routine may decrease resistance over time. After a meal is usually when these patients are at their most relaxed and may be more willing to have oral care done. The decrease in cognitive ability in these patients can sometimes indicate an inability to swallow effectively. To ensure that your patient doesn't choke or experience any type of discomfort, there are aids to prevent this, such as the suction toothbrush, which will suction up saliva, debris, and water as you brush. It's important that as clinicians we don't leave these individuals unattended. Alzheimer's patients tend to experience confusion, and being left alone can lead them to become distraught and disoriented if they forget where they are and what they're doing. Distractions can be effective or ineffective with these patients. You want to make sure that the dental environment is calm and quiet with very few distractions. However, you could also use distractions to your advantage in order to provide oral care for these patients. For example, if the patient is not happy about receiving oral care, methods such as talking, humming, or singing are the most common distractions that are helpful. Every patient will have different needs, and so this emphasizes the importance of individualized care. Using modified aids can be especially beneficial to provide individualized care for these patients. Some patients will be unable to keep their mouth open for long periods of time, can be intolerable of oral care, and can have issues performing their own oral care. A commonly used modified aid within long-term facilities is the Collis curved toothbrush. A Collis curved toothbrush is beneficial when time and tolerance is an issue. Its curved bristles swing inwards to get into the interproximal. They massage the gingiva and enter the sulcus at a 45-degree angle without poking or traumatizing tissue, and achieving a thorough cleaning of all surfaces within a short period of time. Another commonly used modified aid for those who are still able to perform their own oral care is a modified toothbrush handle. Larger handled brushes can be purchased, but also can simply be made by wrapping a cloth around the handle of a brush and securing it with an elastic band. This will help a resident who may have grasping issues, who can no longer hold onto a slim toothbrush handle. Mouth props are also a valuable tool to hold a resident's mouth open while oral care is being provided. Residents can gently bite on the white, spongy mouth prop to help relax the muscles of the jaw. The teeth should be positioned on the ridges. When the prop is resting on one side of the mouth, the opposite side of the mouth can be brushed. These can be washed, labeled, and reused. The handle of another toothbrush can also be used in place of a mouth prop if one is not available. This is called the two-toothbrush technique. Communication and the way that we communicate is extremely important with these patients. Always introduce yourself to the resident and approach within view with a smile. This shows the patient that this is a positive environment. Be sure to explain clearly what you're going to do in case they may have forgotten why they are in the clinic. Use short and simple words and only ask one instruction at a time, and be sure to ask yes and no questions. Understand and use nonverbal cues. Smile and use a gentle touch, and if the patient is biting down, this could be because they are in pain. You could even give the patient a toothbrush to hold in their hand while you are setting up. Positioning. Stabilize your hand by resting on their chin to open up their mouth with your thumb. If your patient is wheelchair bound, lean the wheelchair back for a view into their mouth. It's best to position yourself at eye level in front of the patient. Patients with Alzheimer's often lose peripheral vision. Therefore, positioning yourself behind or beside the patient may make them nervous, confused, or uncomfortable. The hand-over-hand technique is good for patients with dementia because it gives them a sense of control. With the hand-over-hand technique, you can guide the patient through the brushing procedure.
Techniques for those with Alzheimer's disease.
As previously mentioned, it's important for these patients to partake in their own oral hygiene care to feel as though they still have their own independence. If it's not possible for the patient to partake in their own oral care without a caregiver's assistance, the previously mentioned hand-over-hand technique allows the resident to feel as though they are partaking in their own care. Timing of oral care. The timing of oral care is important for familiarity and the sense of routine. Labeling supplies is important so that the individual with Alzheimer's knows what they are and that they're theirs. If they forget them somewhere, they can also be returned to them. To conclude, as of today's evidence, there is an association between the two diseases. However, there still needs to be more high-quality studies to determine if there is a causal relationship. Regardless, the population of patients that is diagnosed with Alzheimer's disease is rapidly increasing, especially in Nova Scotia, so it is evident that we will have these patients in our chairs. What we do know about this association is that it is mostly based on inflammation. So as oral health professionals who deal with inflammation in the oral cavity every day, we have the potential to prevent oral inflammation by providing dental hygiene treatment and offering tips and tricks for at-home care and to caregivers who work with these patients every day.
Our take-home message today for you is that Alzheimer's disease is becoming more prevalent, notably in Nova Scotia. Because this disease is becoming more prevalent, we will continue to see upcoming research based on this association. It is important for oral healthcare professionals to provide individualized care and to be familiar with techniques appropriate for individuals with Alzheimer's disease. What we can do in the office and how we can support and educate the caregivers to provide proper home care can further possibly prevent prevalence of disease. So our last question is the question that we still have remaining. Could you brush for better memory?
Thank you for listening to our presentation on Alzheimer's disease and oral health.